May I ask for our live case panelists, please, to come up. We are going straight away live to lab 2, I think, with Dr. Kinney. May I ask Dr. Rasha Alame, who is the interventional consultant, cardiology consultant at Imperial College, NHS Trust. We're so excited. Senior lecturer at the National Heart and Lung Institute within the Imperial College. Of course, the PI, clinical trialist, PI of the Orbita trial, rocking our world in PCI. Professor Frems, professor of cardiothoracic surgery from University of Toronto. Please join us up on the panel here. Dr. John LaSala, who we can't do a case without you, Dr. LaSala. So nice to have you, of course, and Dr. Bill O'Neill, Dr. Reitman, Dr. Gennaro Sardella, and Dr. Holger Thiel. Fantastic, incredible, and I think those were the 2 new faculty that I presented, and everybody else knows everyone here because we often have Holger and John and Bill. And Rino Sardella is a professor in University of Rome, and it's wonderful to have him, interventional cardiologist. Dr. Kinney, we see you live with Dr. Sweeney. So good morning. Tell us what you got.
Good morning.
Yeah, myself, Dr. Sweeney, I have Isha and 2 as our fellow, and the cath lab team. We have Will, Alina, who is a nurse, Pablo, who is a chief tech, and we have Kiski, who is going to be our imaging faculty. We just, got him on board, and then of course NP Derek Pineda. So if they can put the slides of case number 1 side by side. So this is a 65-year-old male who initially actually presented to an outside hospital out of state, angina for the last few months, with past medical history of hypertension, hyperlipidemia, questionable that he was not tolerating statin very well. And there the cardiologist did a stress test, very interesting, only inferior ischemia with normal EF. We had a cath there outside, which had shown moderate left main, but 3 vessel disease with a syntax of 35 or so. And he was advised to go and have surgery because of 1 vessel that was CTO, and we will show you the rest of the angiogram. Of course, patient declines bypass. He met the surgeon, then came to Mount Sinai to see if it's possible that he can have multi-vessel PCI. So when he first saw me, medication was very little. He was just on aspirin and statin. Subsequently, we started him on some cardiac medication. So here is the angiogram we are going to show you. The right coronary artery was a totally occluded vessel. He came here and we did 2 vessel, 2 stents of the distal RCA and the mid RCA. And here we are for his right coronary artery. So if you see here, moderate left main disease, some dampening as we engage it. So we had to play, create some side holes in the left-sided guide. Circumflex, you can see that it's a mild disease and probably about 30-50% lesion in the LPL and OM2 area. But this is where we are, cranial picture of the LAD. So prox LAD, angiographically mild calcium, but significant calcium in the large size, moderate size diag. That's where we are, and a small ramus. And if you see the left main, not, we haven't engaged it, but we wanted to keep it like that to show that there was a moderate disease. So the residual syntax score after having done the right coronary artery is about 25 with a STS score that was very low. Today our goal is to do the PCI of the left side.
Can we work
if
to
we
make
can,
sure
ask
that
the
your
panel.
mic?
Yes.
No, thank you, Dr. Kinney, excellent. While we're having a discussion, maybe you can work on your mic because your audio comes in and out. So maybe they can do that. In the meantime, fantastic that we have a surgeon here. You saw this. This is a pretty complex anatomy, Dr. Frems. You're on the guidelines. This would be a class 1 indication for CABG. The patient declines. What are we supposed to do? What do you think?
Well, that's a great
Can you press down so you can speak?
Yeah. Hello?
Yeah, go ahead. Just press down and you should be able to.
Well, you're quite right. This would be a class 1 indication for cabbage. In this case, the patient declined. Before he declined, I would make sure that he understood the pros and cons of both. But he selected PCI, and I think the cardiologist, the interventional cardiologist, tackled the CTO first. And if that was unsuccessful, then he may have been represented for cabbage. However, the CTO procedure looks successful, and I'm not going to comment on how the PCI should be done in this case, but I think the order or the sequence looks appropriate.
Yeah, thank you, Steve. That's a really good point. John, you see this a lot. You're looking at this now, and is this mean it's an IVUS? I mean, to me, first and foremost, what's the role of imaging here? And we see, I think, Dr. Kinney's already going in with a rotational atherectomy into the diagonal. But is that for the left main? Is it really a must these days for imaging? And does it need to be? And I mean, it looks like she's going to take care of this. She's approaching the LAD diagonal. We're seeing it already. But what's your take on it?
Yeah, I think all of our PCI trials involving left main had such a low incidence of IVUS that it's really doing a disservice as to how we can maximize our outcomes. I think it's unconscionable that you would do a left main without having some sort of imaging, either OCT or IVUS.
Yeah, so I'm sure Dr. Kinney is going to plan to do that. Any comments, Dr. Teal over there, Holger? How would you approach this? You see, and then we'll go. I mean, you see, we're already immediately moving towards atherectomy into that diagonal. I see it already. What do you think?
Yeah, it's a reasonable approach to go for atherectomy in this case. Honestly, I'm not sure if we really would have at first stage used atherectomy in this patient, but nevertheless, it's a reasonable approach to do it.
Rasha?
Yeah,
so I'm calling everyone by their first name.
Yeah, and that's perfect.
Rasha.
So,
can you press down so we can hear you?
So, I mean, I think it's a fantastic case. I think it's real evidence of the kind of stuff that we see in the labs all the time. My question, I guess, would be, is there any role for physiology here? We can see tandem lesions in the LAD. We know that the patient has angina and obviously 3-vessel disease, and this is a patient that would be outside of many of the trials, but I just wonder whether using physiology might help us just to work out which lesions in that LAD and the left main indeed are important to treat, and also how diffuse that disease might be and whether it would guide, our length of stents and what we need to do in terms of strategy.
Fantastic. Dr. O'Neill, I can't leave without having your comments, and then we'll go to Dr. Kinney.
Just to add something, the other possibility is to do a robotic lima and then treat the other arteries with PCI. I think that kind of is, we always talk about PCI versus cabbage, and I think with centers with expertise, that's a really wonderful strategy which minimizes the invasiveness, which is probably why this patient turned down bypass, but does give him the longevity of a lima.
And by the way, John Puskas does perform those, but it seems like this patient has denied any kind of an open or even a robotic procedure because I'm sure it was contemplated. Dr. Kinney, tell us your plan.
So our plan would be, based on the angiogram, we knew that severe calcium is mostly in the diagonal, so we decided we'll do rotational atherectomy to the diagonal and then decide what to do with LAD, but we did imaging. So if you can show this is the diagonal. If you see that it is about 2.25 to 2.5 vessel, come proximal. So as you come proximal, you start seeing severe calcium, almost 3-quadrant calcium, which goes with the angiographic finding. Initially, we decided on 1.5 bar, but then after having seen this again, we went down, we took a 1.25 bar. And then the LAD we did imaging was mild calcium. So I think we have decided we'll just do, score flex or any kind of a just mild calcium.
And that ostial left main looks.
And significant. Go back to ostial left main.
That's really
this is where we are. 3.9. Yeah. So the way we plan is that we'll do rotational atherectomy of the diagonal Then we will wire the diag, LED, we'll do the cutting balloon of the LED, and left main as we are coming out, balloon the diag, and we'll do dedicated 2-stent technique of the LED diag, and then we will stent the left main and of course optimize it and then do imaging at the end. So I have a 125 burr there. Just we are going to go back in again, going into the left main.
So
There's
do you
no
want to
point
comment
doing
a little bit
this
about the
small burr.
sizing of your burr? Because I think that's an important teaching point for our audience. So imaging actually changed your mind. So it was good to image, to go to a smaller burr size. Do you want to talk about that a little bit?
So, yeah, so what if our current strategy in the severe calcium, the rotational atherectomy Rota burr is just about 0.5 or so. And if you see here, I think 1.5 probably would have been better. The 1.25 just what I say
I would have chosen a 1.5
across. Yeah. Dr. Sharma wanted 1.5. I said 1.25. Probably we should have done 1.25. Okay, so it just moved along. But we have 1.5 burr also if you want to just think that we want to go us with 1.5.
Well, let's get to that point. We now have a lot of devices for calcium modification. Dr. Sardella, Reno, tell us, what's your take on that?
Thank you, Roxana. I think that it's mandatory to perform imaging. Now, at the moment, we have three devices, shockwave, rotablator, and orbital atherectomy. I think that to assess the calcium burden and how is distributed the calcium on the vessel, I think that it's mandatory to choose the better device. I think that in this case, it's the good choice, the rotablator, because it's a very concentric calcium, and to start with 125, I think that it's a good choice too, because I'm used to make a step up of the bar, starting with the smallest, except for the vessel more than 3.
Do we do 1.5?
Any other comments? Anyone would use shockwave or
I think you got
the CSI device? John?
Yeah, I think we're going to discuss this a little bit in some of the noon breakout sessions
Yeah.
on atherectomy. Try to give us some algorithms on how to work through this. Obviously, there's more than one way to do it. CSI would work fine. I favor more rotablator, but certainly CSI I think would work well. We do a lot if, I know it's a little more expensive, but if you see that you've created sort of a pilot hole when you have really dense calcification with an atherectomy device, following up with something like shockwave, if your NC balloon does not further fracture it, is a pretty reasonable alternative. And this is the reason for having these kind of algorithms and the necessity of using imaging both pre, during, and afterwards, because it allows you to go down that pathway to take advantage of the synergism between the devices.
Dr. Reitman?
just-
Governor-elect of Georgia from the American College of Cardiology. Welcome.
Thank you.
Is Scoreflex ready?
Not working. Sorry. Better. I think what's most relevant is what Dr. Kinney alluded to, the fact that the LAD proper didn't have that sort of 270-degree arc of calcium, which a lot of the shockwave literature seems to support. So I think that that's beneficial and leads us, sort of down the road of using primary atherectomy in the diagonal, and then going about it with our usual bifurcation techniques.
Wonderful. So, Dr. Kinney, you seems like you're done with your ablative, and you're bringing in a buddy wire into the diagonal. What's next?
Yeah, so no, I think I agree with all the panel discussion. The question was, should we have done rotational atherectomy versus orbital atherectomy in the diagonal once we know the calcium is severe, which is more than, this was almost 3 quadrant there. Yes, either of the 2 devices would have been okay, but we chose rotational atherectomy. But definitely for LAD, even angiographically as well as on the imaging, since there was not a lot of calcium, there's no indication for any kind of atherectomy. I think I agree with Dr. Lasala, who mentioned that, of course, people now will say after we have done rotational atherectomy, there are 2 ways of handling. Image it, okay, and see what rotational atherectomy has done, and then decide if you need additional, you can consider either IVL, go, go, IVL,
Going up.
or you can do down. Other way of doing it is that you can just do with high pressure balloon first, and if high pressure balloon you see the lesion are not dilated, then you can again consider maybe down.
It looks
IVL
like now
at that
you have
time.
the cutting balloon. What size did you choose? 3.0?
So this is a 3.0 10 millimeter score flex.
Okay.
So we can go high
And we
pressure.
see it
up to
dilating nicely.
20,
It looks like it's
22,
really
20,
expanding.
22 atmosphere, yeah.
That's at 20 atmospheres.
So he said he went up to 20 atmospheres. Now give me the diagonal. So I can use this same balloon to the ostium of the left main. We know we are going to stent it, so I will get the guide out. Yeah, down.
So what's your plan for this bifurcation lesion? So we have a calcific bifurcation
Okay,
and an
go.
ostial left main. So it would be interesting to note.
Go.
And
Yeah.
before you tell us your plan, maybe I can hear from the panel. Rasha, 1, 2
Okay, down.
stent.
You get the ostium.
So, I mean, I think now that we have modified the diagonal, we're committed to a 2-stent strategy. I think in terms of size discrepancy, it kind of takes you away. You know, the diagonal looks smaller than the LAD. So I think I'd be thinking probably, you know, mini crush might work well.
2.5.
Perhaps, you know, I think we'd have to go
2.5,
away
20
from
high.
techniques like the colloque because there's definitely a difference between the two sizes of the vessels.
Excellent. Holger, 1, 2 stents.
No, surely this is a 2-stent strategy in this situation because it's calcific, and she already has done some rotablation in the first diagonal branch and as well a PCI in the LAD. So this must be a 2-stent strategy.
Reno, you're on the bifurcation club.
The bifurcation, first of all, I think that rotablator you can avoid the plaque on the side branch. I think that for this reason it's a good choice too. I would start with a provisional stenting and after rotablator to see if something is changed in the angle of the side branch, because sometimes happens that the rotablator can change the angle or can change the distribution of the plaque. And then I will see, but I would start with the provisional stenting.
Interesting.
18.
Anyone else endorse that? Because I would say 2 stent, but John?
20.
Down.
Yeah, I think you're a little bit too far down the line to go with a provisional stent. I would agree with the approach that Dr. Keeney's taken right now. You know, I'll cite
Ready?
Dr. Sharma's data from the mid-90s that the likelihood of losing a side branch is directly related to how much
Crystal.
plaque there is at the ostium and inversely related to the size of the
I
vessel.
think go to 225.
That the percentages go up dramatically when it's a small vessel with
But
a lot of
225,
disease.
38
And
does not come, right?
Many times
Low
that
pressure.
will
Yeah,
mitigate
it's a
as to
2.5
how I
balloon.
approach a bifurcation,
Okay, low pressure.
knowing that there's a high likelihood of compromise.
Yeah.
I'd
Okay,
more
good.
commit to a 2-stent strategy.
Yeah, and that's good. And I'm hearing you thinking about sizing. So Dr. Kinney, it seems to us that you're going with a 2 stent. Is that right or no?
Yeah, that's right. I think that was an excellent discussion amongst the faculty there,
225.
saying why provisional stenting. I think you can see how the bifurcation club, we have a bifurcation club here in the United States, recently started by the SKY by George Dangus, a big group of people. Of course, the European Bifurcation Club people are also part of it, but always the teaching has been that provisional stent, provisional stent, provisional stent. But there are certain cases when you want to say that you want to do dedicated
Why are we seeing an empty
two-stent,
room?
technique.
Go on. Yes.
Yeah.
We're seeing an empty
So-
room. We want to see you.
Promise.
Okay, you can see.
22538.
Okay, 2538. So, dedicated two stent will be side branch is large, side branch has significant disease, or side of, they always mention about the angle, which is less than 45, more than 70 degrees, or the length of the lesion. The length of the lesion here, if you see here, almost 30 millimeters, significant side branch. And this is a, moderate to large size diagonal. So based on all that criteria, it's better we go with the upfront two-stent technique, which I think majority of the people
So before you
agree.
show us your 2-stent technique, our video is showing an empty cath room.
22538.
So please tell your videographers to show us there we go. Thank you. But I'm seeing it. Oh, there it comes. Okay, excellent. Because our, excellent. So tell us exactly what,
and a
did you choose a 225 for that side branch? I'm hoping not. You will post
No,
dilate.
we are taking a 2.5. We are taking a 2.538 to the
good.
side branch.
Good.
Of course, we don't have a 48 2.5. Doesn't come with a 48. Then we are going to take a 3.0, okay, 20 to the LAD. So we will do a mini crush technique of the LAD diagonal. Once that is done, we will recross KISS, and as we are coming out, then we will stand the left main. Yeah.
Do you think you're undersizing for that LAD? What was the size of the vessel? I never
Actually,
want to
on the
think
IVUS,
that a
2.7.
65-year-old man has a 3.0 proximate LAD.
No,
I'm always
he's
thinking it's a 3.5. But, you know, you had the imaging.
2.7. Yeah, no, that's not the thing. After the septal, come back, proximal. Come proximal.
The
to
distal
level of the
reference is
septal.
actually smaller than we
Yeah.
thought.
So distal reference is 2.5, but I think at the level of the septal, look at that, what we are getting, 2.7 max we got. That's
I see.
stretchy.
Okay.
Yeah.
That's kind of surprising.
He's
There's
not,
some
no
negative
history of
in mind.
diabetes. Hemoglobin A1C is well normal in this guy, but behaves like a diabetic vessel.
Yeah, it's interesting. Okay.
So they
tell
can
us what
play the
you're doing.
video of the mini crush technique, non-left main disease.
So you're really
a small
covering the
branch there.
entire disease segment, very long stent in that side branch. So I hope you get
Yeah,
a really
but,
good result
yes,
there.
sir.
And
And I
then,
can tell you, he's on clopidogrel. On clopidogrel, his PRU today is 60. Because one thing for sure, somebody with multiple stents, I think already discussed by Dr. Sharma in this kind of, no high bleeding risk, but he's a guy who could probably do with some, intense
More
DAP,
potent
but I
agents,
think
yeah.
if the PRU is already that low, we don't want to go to a potent agent. Then
John?
definitely there's a risk of bleeding.
John has a comment.
Joe,
John?
I think it underscores a key thing that for those of us who thought that we're so good that our eyes were instantly calibrated to what the appropriate diameter is and the length, they were constantly readjusting as a result of IVUS and OCT.
Yeah.
Whether it's usually it's a larger vessel than we think, and it's always longer than what we think. So we've been missing a lot of these over
16?
the years, and for those who don't do it routinely,
Yeah,
you're
that's
still
what I
missing it.
was. Okay. Okay, good.
Can I just
Okay,
ask,
ready? Take a picture.
on
So
what
you
basis
can,
was
is a video
chosen-
playing by the side?
Go.
just the length of the LAD stent? Because the LAD
Yeah.
looks quite diffusely diseased, and I just wonder
Yeah.
whether...
So do you think your length of your stent in the LAD is appropriate, Dr. Kinney? I'm thinking you need a little bit longer than that.
Okay. We could go longer. I actually wanted 16, but your IVUS measurement said 19. I would have gone
I'm thinking 23.
24. Give me a
24,
275, okay? Because distal is not big. 24. So we will go larger in the,
And then
longer
you'll
in the
just,
LAD.
you'll
okay?
just plump it up with a bigger balloon, I think like a 3.0 at least, or maybe even
When
a
we
3.25 balloon.
when we are going to do the final KBI, definitely it will the proximal will
Bill,
be
you
okay.
have a comment?
Yeah, I think that we've done a wonderful job of measuring lesion width with IVUS, and our eyeball is terrible for that. Similarly, lesion length is terrible, and here in this case, you kind of wasted one stent. So I think a tool that would measure lesion length, I'm working on one, so that's a conflict, but I think we need something simple to measure lesion length for these cases.
Yeah.
Rox, why you didn't perform a DK crush? Just-
Yeah,
but
so
just
good
a-
question.
just a
I
crush.
think a lot of people are mesmerized by DK Crush and it's whatever those superior results from the work that Shalin Chen has done. But in our lab, we feel like we're getting excellent results with imaging, even doing this mini crush and not
Dylan,
really
this is-
going
oh my
through
God.
the difficult, long journey of the
Shall I?
DK Crush in most of our
Yeah.
cases. So Dr.
Okay,
Kinney, maybe
good.
you can tell me, you have
Up on the
an
dial?
app
Yeah.
that,
Ready?
that helps us with bifurcation in
Going
your
up.
bifurcation app. Would your bifurcation app tell us we should be doing a DK Crush or a mini crush here?
So our bifurcation app actually, if you take about that, we will talk about a DK crush, mostly in left main, non-left main also. We always say left to the discretion of the operator. Now going back to the decay crush 5, how the study was done. So they had to have, people have already done over 100 left main PCI. They had to do decay crush steps and over 30 cases or so. Only when approved by the committee, they were allowed to do the technique. So it's not an easy technique to be done. And we are showing you how the same thing could be done, okay?
So can you go over these steps with us just now, what you just did? So you place the stent into the, go through step by step, because that's what we promised our audience.
Yeah.
Good. So we place the side branch stent. Yeah, we side branch stent first. Once you place the side branch stent, you go to the main vessel, place the main vessel stent. You make sure 1 millimeter. So actually when you're doing mini crush, we are actually talking with micro crush, which means just a millimeter of the side branch stent is sticking into the main vessel. Once you are happy, then we deploy the side branch. Once you do that, the SDS comes out. You just give some dye, make sure there's no dissection. Once that is done, you remove the wire. Never leave the wire in the side branch. Once that is done, you remove the wire and then you inflate the main vessel. That's what we did. We did the main vessel coming out. We'll take a picture now.
And now you come with your side branch.
Yeah. So everything looks good. So far, everybody's, you see that the lesion is covered. So now my side branch wire is still in the guide, and I'm going to try to recross.
And you've already dilated that left main ostium with your cutting balloon, so things are looking pretty good and hemodynamically very stable. We see the hemodynamics in the side there. Everything is looking good.
Dr. Keeney, would you do
any questions, any comments?
Dr. Keeney, would you do a proximal optimization first before you cross?
For non-left main, I'm not a fan of doing a pot. I think we can show some papers side by side, especially the ProPot trial that was just came out. They did OCTs, and in fact, when they did pot, they saw more strut of the OCT covering the side branch, saying that compared to just doing a kissing balloon. This is something I was a proponent of having said that for years together. No, this is one thing, yeah. And now I'll try to recross the side branch. And also we have our own paper that they can also show side by side, where we do so many bifurcation. So we compared OCT with the endothelial flow, which we did. So cutting below, KBI versus a pot, no difference. Because what is the biggest thing people say? Now we recross with the same filter wire that was in the guide.
That was a beautiful
biggest
rewiring
thing what people,
through, only in your hands, Dr. Kinney. Beautiful. Make it
Thank
look
you.
a little bit harder.
Any special wire you favor? Any special wire do you favor, for Dr. Keeney, on that side branch reentry?
Yes, he make it a final.
Yeah, the side branch, again, there's, question what they would like, but we always like polymer jacketed wire, whether it is Fielder or Whisper. I'm a fan of Fielder. Dr. Sharma is a fan of Whisper. So it depends. And what we say, there's always, many people are worried when it's a polymer jacketed wire that they will be worried because there are reports to show that a polymer jacket can be stripped off. But that's only if you leave. Give me the LED. If you leave the wire in the side branch, which we did not leave the wire in the side branch. But if you are doing provisional stenting and we want to leave the wire in the side branch, we still use the polymer jacketed wire, which we just said. And usually they keep a memory, you see that? So we leave it in the guide itself. You don't have to remove it out. So you're shortening the steps.
So are you going to do a little post-dilatation more distally before you do with that balloon in that side
No,
branch?
I think with the vasodilators should take care of that. And what we will do is now we have a 3O
in the
NC
distal end
and
of
a
the stent, I feel like it's
the-
not
yeah.
fully dilated yet.
So this is a hissing.
So
Good.
tell us the sizes of the balloon you have, the
Your serial?
3.0 and a 2.5, right?
So, yeah, 3O and a 2.5. So remember for the LED, we took a 275 stent. Distal vessel we thought was 275 even based on, so I'm going to pull back. So when you're doing this, yeah, go up for the diagonal, high pressure, 16, 18, to make sure the ostium. Good, okay. And now LAD, individually we go up and then we do the kiss. And when we are doing kiss, we'll go moderate pressure, maybe 8, 10 atmosphere, that's it.
18.
Good. And John, I know you asked a question, and while we are imaging, you can see it, that we have done so many cases with the mini crush technique without pot, and while you image, you will see the proximal edge is go up with the both 8 atmospheres.
Yeah, I was actually kind of setting you up for that.
Hold on.
And you answered it well.
Down.
If you're,
So we can see it. Yeah, go.
yeah, if you're IVUSing and you don't have this huge malapposition of the stent strut, then
Yes.
you're right, you don't really have to do the pot.
Good.
Okay, down. But you are true. I would not say that do not do pot for non-left main in every case. Like Rasha initially mentioned, that if there's a big mismatch, that you have a 4.0 LAD and the distal vessel is 3.035, you're placing 3.0 stent, 3.5 stent, and the proximal has to be optimized in that situation. But here, everything looked okay. So we'll take a picture now. If you want, we can image, and then we'll image the main vessel so you can see that IVUS. Or I think we can put the left main stent. Are they ready
Yeah,
in
and
the
maybe
other
some
room? When does they
vasodilators
want?
for that distal LAD as well. It looks like it's a little bit,
Yep.
you know, and maybe you'll do some nice imaging. Arthur, did you want to have a comment?
I think that one of the most important things we've moved beyond, which is, yes, that optimization of the carina, the stent size, all those things, but vessel preparation, which Dr.
Yeah.
Sharma and Dr. Kinney spent so much time emphasizing when we were in training. I think the principles are the same, and it allows you to accomplish a result like this. Vessel preparation, first, second, and third, allows you long-term durable results, which are superior to sort of not taking care of it from the get-go.
One other point too, that, you know, most of these people that you're doing multi-vessel stenting on have diffuse disease. There's no normal reference area. So you can become over-exuberant as well in trying to stent the entire LAD, which I would never recommend. So what you want to do is find a reasonable zone that has maybe only modest disease and not significantly narrowed. And that disease downstream at the present time, there's really no benefit to going after that.
Too long.
So sometimes you have to restrain your enthusiasm too based on what you see.
Now, what is an ideal?
Yeah, I was going to
I
ask.
will see that ostium is fully covered. Yeah, some die.
Yeah,
You
in
don't see
terms
the
of
ostium. Okay,
length
this I
of
think
that-
the ostium looks good.
Yep.
Same. I'm just going to pull back the guide.
In terms
Okay.
of length of that left main stent, it's difficult, isn't it? Because either you just cover the ostium and keep
Yeah,
it
we
short,
did not
or you join
decide.
them up.
Remember the
and
body.
it's-
Yeah, good. Okay.
Going
Got-
up.
Yeah. So the body of the left main was okay. We didn't want to cover the bifurcation. This guy does have a disease elsewhere. Down. Go in. So we will, left main definitely needs a post dilation.
Do you have any comments about how you find the ostium of the left main? That always seems to be a problem in terms of getting it in
Go.
and not missing the actual ostium.
No, really
Excellent
important.
question.
Did you hear
So
that,
that's
Dr.
why I
Kinney,
moved.
about the ostium and
Yes,
how
yes,
we've
yes.
got to be very careful about not missing that ostium? So what are some of your
Yeah.
tips
We
and
will,
tricks?
we will image it and show how we got it right. I will tell you, in the cranial view is the best view actually. So whether you want to go a little bit RAO, straight AP cranial, or LAO. Here we went little LAO to see it. So take a picture. And then to make sure it is fully covered. So in this view, you see that? Does not look like that way. I will go another view. LAO cranial. Okay, good.
It always looks worse when you fix the proximal part. And again, that's
Yeah.
you have to decide where you want to cut. Draw.
So the way the left main is taking off, you see there you will have few struts sticking out in the inferior part of the left main, but definitely in the superior part, it is up to the ostium, and you know, you can see one strut sticking out.
So you're going to
So we'll do the
now.
imaging right now. Yeah.
You know, one trick I like to use, since you've got the IVUS down there anyways, is to use the transducer site on the IVUS to mark where the ostial of the left main is, or any other spot for that matter, but for the ostial of the
Right,
left
while
main.
you're imaging, before you're...
So in there, just take
yeah,
a picture
it's
when
always
you're
a
right
good-
there, and don't move anything after that. And then
Yep.
use that as your reference spot.
It's a great tip.
And
Any other ones?
I think Dr. Kenny's also demonstrated, although she does things so quickly, but she's demonstrated how she's been manipulating the catheter back in over the balloon, because we see so many times those ostial left main stents get damaged by us going in and out with the catheter.
That's right. Really, really important,
Okay,
important
I'll
point.
start to work.
Yeah,
So,
Rasha pointed
Dr.
out an
Kinney, is there
important
gonna be a-
thing. Yeah,
Is there going to be a second case, because we're getting close to the time of...
yeah.
Because...
No, there's a second case, they're ready in the other room. You see the IVUS and you go, if needs proximal optimization of the left main, I will do that. But to me, looks like it's fully opposed, even the left main stent. So just to finish, our total contrast volume was 130 cc with a air karma of 0.8.
I feel like you could squeeze that a little bit more, the LAD stent, that
Come to the
proximal.
bifurcation. Now it's a native. This left main bifurcation. This left main is not covered.
Bring the
The
guy
body
down.
is normal. Yeah, this is the edge of the left main stent. Looks perfect. It's coming. Expand it. Come to the ostial. Yeah, stick to the aorta to cover the lesion.
No,
It's
there's a
perfect.
couple of millimeters into the aorta. But it looks like
No,
you
that
have
I
a little
remember
bit
I
more
mentioned that.
optimization to do in the LAD diagonal from my look. But let's go to the other lab. Is that okay? You've done an amazing, amazing
Yes,
job.
we are
Thank you,
done.
Dr. Kinney. Beautiful.
Thank you.